Treatment of Cushing's syndrome, an Endocrine Society clinical practice guideline. In patients with overt Cushing's syndrome (CS), we recommend normalizing cortisol levels or action at its receptors to eliminate the signs and symptoms of CS and treating comorbidities associated with hypercortisolism. We recommend against treatment to reduce cortisol levels or action if there is not an established diagnosis of CS. We suggest against treatments designed to normalize cortisol or its action when there is only borderline biochemical abnormality of the hypothalamic pituitary adrenal (HPA) axis without any specific signs of CS. The benefit of treating to normalize cortisol is not established in this setting. Optimal adjunctive management. We recommend providing education to patients and their family caretakers about their disease, treatment options, and what to expect after remission. We recommend that all patients receive monitoring and adjunctive treatment for cortisol-dependent comorbidities, i.e., psychiatric disorders, diabetes, hypertension, hyperkalemia, infections, dyslipidemia, osteoporosis, and poor physical fitness. We recommend that a multidisciplinary team, including an experienced endocrinologist, takes patient values and preferences into consideration and provides education about the treatment options to the patient. We suggest evaluating CS patients for risk factors of venous thrombosis. In patients with CS undergoing surgery, we suggest perioperative prophylaxis for venous thromboembolism. We recommend that clinicians discuss and offer age-appropriate vaccinations to CS patients, particularly influenza, herpes zoster, and pneumococcal vaccinations. We recommend initial resection of primary lesion, underlying Cushing's disease, CD, ectopic and adrenal, i.e., cancer, adenoma, and bilateral disease etiologies, unless surgery is not possible or is unlikely to significantly reduce glucocorticoid excess. We recommend unilateral resection by an experienced adrenal surgeon for all cases of benign unilateral disease. We recommend localizing and resecting ectopic ACTH secreting tumors with node dissection as appropriate. We recommend transsphenoidal selective adenomectomy (TSS) by an experienced pituitary surgeon as the optimal treatment for CD in pediatric and adult patients. We recommend measuring serum sodium several times during the first 5-14 days after transsphenoidal surgery. We recommend assessing free T4 and prolactin within 1-2 weeks of surgery to evaluate for overt hypopituitarism. We recommend obtaining a postoperative pituitary magnetic resonance imaging (MRI) scan within 1-3 months of successful TSS. Remission and recurrence after surgical tumor resection. We suggest an individualized management approach based on whether the postoperative serum cortisol values categorize the patient's condition as hypocortisolism, hypercortisolism, or eucortisolism. We recommend additional treatments in patients with persistent overt hypercortisolism. We recommend measuring late-night salivary or serum cortisol in patients with eucortisolism after TSS, including those cases where eucortisolism was established by medical treatment before surgery. We recommend using tests to screen for hypercortisolism to assess for recurrence in patients with ACTH-dependent CS. Glucocorticoid replacement and discontinuation and resolution of other hormonal deficiencies. We recommend that hypocortisolemic patients receive glucocorticoid replacement and education about adrenal insufficiency after surgical remission. We recommend follow-up morning cortisol and/or ACTH stimulation tests or insulin-induced hypoglycemia to assess the recovery of the HPA axis in patients with at least one intact adrenal gland, assuming there are no contraindications. We also recommend discontinuing glucocorticoid when the response to these tests is normal. We recommend re-evaluating the need for treatment of other pituitary hormone deficiencies in the postoperative period. Second-line therapeutic options. In patients with ACTH-dependent CS who underwent a non-curative surgery or for whom surgery was not possible, we suggest a shared decision-making approach because there are several available second-line therapies: AIG, repeat transsphenoidal surgery, radiotherapy, medical therapy, and bilateral adrenalectomy. We suggest bilateral adrenalectomy for occult or metastatic ectopic ACTH secretion. ACAS-R is a life-preserving emergency treatment in patients with very severe ACTH-dependent disease who cannot be promptly controlled by medical therapy. We recommend regularly evaluating for corticotrope tumor progression using pituitary MRIs and ACTH levels in patients with known CD who undergo bilateral adrenalectomy and in patients who undergo this procedure for presumed occult ACAS, because some of the latter have pituitary and not an ectopic tumor. Radiation therapy, radiosurgery. We recommend confirming that medical therapy is effective in normalizing cortisol before administering radiation therapy, RT, radiosurgery for this goal because this will be needed while awaiting the effect of radiation. We suggest RT, radiosurgery in patients who have failed TSS or have recurrent CD. We recommend using RT where there are concerns about the mass effects or invasion associated with corticotroph adenomas. We recommend measuring serum cortisol or urine-free cortisol, UFC off medication at 6 to 12-month intervals to assess the effect of RT and also if patients develop new adrenal insufficiency symptoms while on stable medical therapy. Medical treatment. We recommend steroidogenesis inhibitors under the following conditions, as second-line treatment after TSS in patients with CD either with or without RT, radiosurgery as primary treatment of ACAS in patients with occult or metastatic ACAS and as adjunctive treatment to reduce cortisol levels in adrenocortical carcinoma, ACC. We suggest pituitary-directed medical treatments in patients with CD who are not surgical candidates or who have persistent disease after TSS. We suggest administering a glucocorticoid antagonist in patients with diabetes or glucose intolerance who are not surgical candidates or who have persistent disease after TSS. We suggest targeted therapies to treat ectopic ACTH syndrome. Approach for long-term follow-up. We recommend treating the specific comorbidities associated with CSIE, cardiovascular risk factors, osteoporosis, and psychiatric symptoms in all patients with CS throughout their lives until resolution. We also recommend testing for recurrence throughout life except in patients who underwent resection of an adrenal adenoma with a computerized tomography (CT) density of 10 Hounsfield units. We recommend educating patients and families about the clinical features of remission. In patients with adrenal adenoma, we suggest follow-up tests for the specific comorbidities associated with CS if the adenoma density on CT was 10 Hounsfield units. For those with higher Hounsfield unit values or pathology consistent with possible carcinoma, we suggest evaluating for malignancy using imaging. We recommend that patients with Carney complex have lifelong follow-up tests for cardiac myxoma and other associated diseases, testicular tumors.